Let's take a moment to consider what a marvelous age we live in. Can you imagine what it was like living in a world of no antivirals, no antibiotics, and no vaccines? Smallpox, measles, chickenpox, hepatitis B, pneumonia, polio, diphtheria, and so many other infections that we can prevent with immunizations and treat with powerful drugs today could mean serious illnesses or even death back then. Still, we're faced with our own infectious disease challenges and are searching for vaccines and new drugs to battle the medical challengers of this age. HIV and AIDS are certainly on the top of that list. Let's review HIV disease, starting with the basics of viral transmission. We'll begin with the risk factors for contracting the human immunodeficiency virus. HIV is transmitted via direct contact with contaminated body fluids, specifically blood, semen, vaginal secretions, and breast milk. That makes this a preventable disease. The most common methods of transmitting the HIV virus are through unprotected vaginal, anal, or oral intercourse, injection drug users sharing contaminated needles, and pregnant women passing the virus to the fetus. What can be done to prevent transmission of the virus? Some barriers for preventing contact with blood and mucous membranes are at least partially effective, like wearing gloves when handling contaminated blood or body fluids, and practicing safer sex by using latex condoms or female polyurethane condoms during oral, anal, and vaginal sex. Injection drug users must be taught never to share needles and syringes. And we, as nurses, should never recap contaminated needles. That helps prevent accidental needle sticks. Casual contact is not a major consideration here. Although researchers have found HIV in the saliva of infected people, so far there's no evidence that the virus is spread by sharing eating utensils or kissing. But remember that the bathrooms of people living with HIV should be cleaned with a 10% bleach solution to kill the virus that might remain in any residual body fluids. You know, this is really just good common sense. These precautions should become second nature. You shouldn't handle anything that might have blood in it, such as stool or draining wounds, without wearing gloves. Now let's discuss how HIV infection leads to AIDS. People with HIV infection do not have AIDS unless the virus has caused enough immune system damage to open the door to opportunistic infection with all the signs and symptoms that come with it. In fact, the CDC has developed a classification system to help clinicians determine where their clients fit within the spectrum of HIV disease. HIV infection is at the start of the continuum, and AIDS is at the far end. We know that an HIV-infected person can remain healthy for many years. But even during the asymptomatic period, the HIV virus is very busy multiplying, infecting, and killing immune system cells. This asymptomatic period is highly variable. It can be as short as a few months or as long as 10 years. Eventually, the supply of the immune system's infection fighters, the CD4 positive T cells, dwindles to the point where various infections start taking over. It is that advanced stage of HIV infection that is called AIDS. More specifically, an HIV-infected person is diagnosed as having AIDS when he or she has a CD4 plus T cell count fewer than 200 per cubic millimeter of blood. Normal is 1,000 or more, and/or at least one of more than 24 opportunistic infections and conditions. The most common AIDS-defining condition in both men and women is a lung infection called pneumocystis carinii pneumonia, or PCP. Other AIDS-defining conditions are severe body wasting and candida infection of the esophagus, windpipe, or lungs. We'll discuss this in more detail shortly. Okay, here's a question for you. How do people know if they've been infected with HIV? Well, they don't unless they're tested. Once a person's infected, it can take several weeks for the immune system to recognize the virus and produce antibodies to it. Once that happens, a blood sample can be analyzed for the presence of antibodies. The HIV enzyme-linked immunosorbent assay, called ELISA, is the most commonly used test to screen for HIV antibodies. If the immunoassay is positive for antibodies, the person is said to be seropositive. If no antibodies are detected, the person is said to be seronegative. A more specific test called a Western blot is used to confirm HIV infection after a positive ELISA result. There are also tests that detect the virus itself, but these tests are expensive and are rarely used for screening purposes. According to the Centers for Disease Control and Prevention, a person is said to have HIV infection when there's a positive result on a screening test for HIV antibodies, followed by a positive result on a confirmatory test for HIV antibodies. But if a person is infected but hasn't produced enough antibodies to be seropositive, the person is still communicable and can transmit the virus. The time period between when a person's infected and when antibodies are produced is called the window period. We know that once the virus infects a person, the speed with which it destroys the immune system is highly variable. So what alters disease progression? This is an important part of educating a newly diagnosed client. Here are the cofactors that play a role in how fast the virus becomes life-threatening. Nutrition, lifestyle habits such as smoking, and the presence of other diseases such as tuberculosis or hepatitis all have an impact. The more cofactors present, the faster a person is likely to develop AIDS. Let's review what happens when the virus infects cells. HIV targets the CD4 positive T cell, also called a T helper cell, which is an important immune system cell. T helper cells, or T cells, help other cells in the immune system, such as B cells, produce adequate amounts of antibodies to fight off foreign invaders, such as bacteria and viruses. When someone becomes infected with HIV, the retrovirus travels to and invades T cells. The virus then splices its RNA onto the DNA of the host cell with the help of an enzyme called reverse transcriptase. After that, the T cells manufacture new viruses instead of new T cells. Once the new viruses are released from the infected T cell, the T cell dies, and eventually this loss of T cells damages the immune system irreversibly. It's a very efficient virus, isn't it? HIV targets the exact cells that could have destroyed it. Now, in assessing a client who has AIDS, what objective and subjective data would you expect to find? The subjective data could be headache, paresthesia, photophobia, loss of appetite, abdominal discomfort or pain, rectal itching and/or pain, severe fatigue, and malaise, nausea, difficulty swallowing, blurred vision, and diplopia or double vision. Objective data includes cough, dyspnea, wheezing, tachypnea, cyanosis, hemoptysis, intercostal retractions, memory impairment, decreased concentration, confusion, unsteady gait, decreased hand coordination, tremors, seizure, depression, emotional instability, psychoses, mouth lesions, skin lesions, diaphoresis, dry skin, delayed wound healing, vomiting, diarrhea, an enlarged spleen called splenomegaly, and fever. You see, the clinical manifestations of AIDS vary with the type of opportunistic infection the person has. It can be dyspnea, fever, and cough in the person with PCP, or mouth lesions in the person with candidiasis. There are a lot of opportunistic disorders such as tuberculosis, Mycobacterium avium complex infection, cryptosporidiosis, Epstein-Barr, cytomegalovirus, and Kaposi sarcoma. Your client would have clinical manifestations for the particular infection. And what about wasting syndrome? Wasting syndrome is a cachexia or severe wasting that develops in people with AIDS related to inability to eat, general decline in health, and loss of immunity. It is defined as the involuntary weight loss of 10% of baseline body weight, plus either chronic diarrhea or chronic weakness and chronic fever in the absence of any other illness that would explain it. Let's say that you're caring for a client who has AIDS. What would your top priorities be? Since pneumocystis carinii pneumonia and tuberculosis are common in clients who have AIDS, their gas exchange would be impaired. So you would monitor the client's respiratory status, rate, rhythm, and depth plus breath sounds at least every 4 hours, and PRN to determine changes from baseline. You would monitor arterial blood gases if ordered, administer oxygen if needed, and try to get the client to breathe deeply and cough to clear the airway. Raising the head of the bed and encouraging relaxation exercises will also facilitate breathing. The client may need help with activities of daily living, especially since fatigue can be overwhelming. You would look for skin breakdown and signs of fluid volume deficit, especially if the client has diarrhea. You'll want to see whether or not the client can eat and drink. Does he have mouth lesions? Are his mucous membranes dry? Is his anal area excoriated? You would then have to plan interventions for whatever you find. Mechanically soft foods, a soft bristled toothbrush, nutritional supplements, keeping the skin clean and dry, frequent turning and repositioning, and so on. Analgesics might help reduce pain so that the client can better participate in his care. What other nursing diagnoses can you think of? There's risk for infection due to the suppressed immune system, altered thought processes related to AIDS dementia, pain, physical disability, or opportunistic infections, diarrhea related to opportunistic infection, fluid and electrolyte imbalance related to frequent watery diarrhea, altered nutrition, less than body requirements related to anorexia, nausea, vomiting, altered oral mucous membrane integrity related to opportunistic infections, risk for impaired skin integrity related to immobility and nutritional deficit, fatigue related to the disease process, anticipatory grieving related to changes in physical condition and prognosis, and social isolation related to the stigma of having AIDS. It may seem that this list is more appropriate for the client who has AIDS, but some of the same diagnoses apply to the person who has just been diagnosed with HIV infection. However, someone newly diagnosed would be at risk for the problems rather than experiencing them just yet. What would be the priority for the newly diagnosed client? Knowledgeable deficit would be the priority problem because she would need to learn about healthy lifestyle habits such as eating a well-balanced diet, getting adequate exercise without becoming overly fatigued, quitting smoking if applicable, and certainly keeping follow-up appointments with practitioners. Practicing safer sex would be a must, so you would have to assess the client's knowledge base and fill in the gaps. You would also want to teach her about antiretroviral medications, often called HAART, which stands for Highly Active Antiretroviral Therapy. The usual HAART regimen combines 3 or more different drugs, such as 2 nucleoside reverse transcriptase inhibitors, called NRTIs, and a protease inhibitor, 2 NRTIs, and a non-nucleoside reverse transcriptase inhibitor called an NNRTI, or various other combinations. These treatment regimens have been effective in reducing the amount of virus and slowing disease progression. So let's talk about these medications. When is the ideal time to start HIV-positive patients on the antiviral agents? The CDC guideline for antiretroviral therapy is that treatment should be offered to people who have fewer than 350 CD4 positive T cells per cubic millimeter or plasma HIV RNA levels greater than 55,000 copies per milliliter. The recommendation to treat asymptomatic patients is based on the willingness and readiness of the person to begin therapy, the degree of existing immunodeficiency, and the risk for disease progression is determined by the CD4 positive T cell count, the level of plasma HIV RNA, and the potential benefits and risks of initiating therapy in an asymptomatic person. Can you recall the types of drugs used for HIV and AIDS? They are nucleoside reverse transcriptase inhibitors, NRTIs, non-nucleoside reverse transcriptase inhibitors, NNRTIs, and protease inhibitors. When these drugs are used in combination, they prevent replication of the virus at different stages within the process. By doing this, they keep the virus from using the T cell to produce more viral particles and spreading. Using a combination of drugs also helps prevent drug resistance to some extent.